I came across an 87-year-old female with severe unilateral electric-like pain lasting for 20 to 30 minutes, which only happens at night but every night. It is associated with ipsilateral nasal congestion and tearing, and it can be prevented by taking 200 mg ibuprofen. Although we still are not sure about the patient's definitive diagnosis at this point, this led me to review trigeminal autonomic cephalalgias. Trigeminal autonomic cephalalgia includes episodic and chronic form of cluster headache and paroxysmal hemicrania, as well as SUNCT, which stands for short-lasting unilateral neuralgiform headache attacks with conjunctival injection and tearing. Although pathophysiology of these headaches are still not clear, involvement of hypothalamus and nitric oxide are thought to play a major role. Cluster headache is more commonly seen in men than women. Onset age usually ranges from about 20 to 40 years of age. Attacks usually occur in series lasting for weeks or months, separated by remission periods. And criteria for this condition is shown here. In short, unilateral orbital, supraorbital, and/or temporal pain lasting for about 15 to 180 minutes, accompanied by autonomic presentation. It must have at least 5 attacks, frequency ranging from 1 every other day to 8 attacks per day. Treatment is usually abortive due to short-lasting attacks, including triptans, oxygen, octreotide, and lidocaine. Corticosteroid may be used short time as a preventive. Other preventive medications are verapamil, lithium, topiramate, valproate, and etc. Deep brain stimulation of the posterior hypothalamic region is now considered as an option, and also greater occipital nerve blocks has been attempted. Paroxysmal hemicrania has very similar characteristics with cluster headache, but it is shorter lasting, with more frequent episodes, occurring more commonly in females, and responds absolutely to indomethacin. And this is the criteria. It is pretty much the same with cluster headache, except for the shorter duration of pain of 2 to 30 minutes compared to 15 to 180 minutes of cluster headache, and more frequent episodes, at least 20 attacks, or at least 5 per day for more than half of the time. Paroxysmal hemicrania also must respond to indomethacin. So indomethacin 75 mg BID for 3 days is used for indomethacin test to confirm the diagnosis of paroxysmal hemicrania. Maintenance dose usually ranges from 25 mg to 100 mg per day, and pretty much done by titration. Because indomethacin commonly causes gastritis, Cytotec is commonly prescribed with indomethacin, 200 micrograms 4 times a day. At last, SUNCT. It is a relatively rare condition characterized by short-lasting attacks of unilateral pain that are much briefer than those seen in any other TAC, and very often accompanied by prominent lacrimation and redness of ipsilateral eye. For treatment, abortive is not useful because of the short-lasting duration of the symptoms. Lidocaine is used for short-term prevention, but anticonvulsants such as lamotrigine, topiramate, gabapentin, and carbamazepine are used for longer-term preventive medication. Microvascular decompression of the trigeminal nerve, greater occipital nerve block, and hypothalamic deep brain stimulation are attempted for surgical intervention, but without significant evidence for good results. So, that was the brief overview of trigeminal autonomic cephalalgias, cluster headache, paroxysmal hemicrania, and SUNCT, or short-lasting unilateral neuralgia form headache attacks with conjunctival injection and tearing. Thank you for listening to my presentation.